Good morning. I'm Robi William. I'm an MD second year student. May I know your name and your age, please?
I am Charles William, 58 years old.
Okay, Charles William. Today we are going to do an abdominal examination for you. Is there any concerns that you came here today? Do you have any problems like that?
No, sir, no.
No problems. Just you came here for a
General,
abdominal examination.
general examination.
Okay. I will ask some problems if it's there. You can tell me freely.
Okay.
Do you have any indigestion or any digestion problems?
No, sir.
No. Have you vomited recently?
No, sir.
No. Okay. You have no trouble in eating also?
No.
No. Okay. Do you have any constipation like that? No. Or
No.
it's
No.
no. Okay. Let's see abdominal examination today. I will be touching your stomach and giving little pressure. It may feel a little bit uncomfortable for you. If it's okay, we can proceed to the examination.
Okay, sir.
Okay. Now we will proceed. I've cleaned my hands. Before the examination, I've made sure that the patient has emptied his bladder.
I am asking the patient to lie down and relax and exposing the supine patient's lower abdomen by raising the gown to below the nipple line. I am inspecting the skin for scars, striae, dilated veins, rashes, or ecchymosis. I am inspecting the symmetry and contour of the abdomen, checking if it is flat, rounded, protuberant, or markedly concave or hollowed. I am checking if there are any bulges. I am observing the contour of umbilicus and looking for signs of inflammation or hernias or peristalsis of aortic pulsations visible in the epigastrium. I am warming my hands and my stethoscope. I am listening for bowel movements by placing the diaphragm of the stethoscope gently over each quadrant and listening to the abdomen before performing percussion, because these maneuvers may alter the frequency of bowel movements. If the patient has high blood pressure or atherosclerosis, I will listen in the epigastrium over the aorta, then listen over the iliac arteries and the femoral arteries. Next, I am lightly percussing the abdomen to assess the distribution of tympani and dullness. Tympani is a high pitched musical sound that indicates a hollow space filled by air or gas in the stomach or intestine. Dullness suggests fluid or underlying organs like the liver and spleen.
Okay, Mr. Charles, make sure to stay relaxed, okay? If I will be palpating your stomach and your abdomen area, if you feel any tenderness, you say immediately, okay? Relax.
I am now palpating the four quadrants of the abdomen, beginning gently and saving painful areas for the last. With my fingers together, placing my hand flat on the abdomen and pressing using a light dipping motion, I am moving smoothly, palpating all quadrants. I am identifying for any tenderness or increased resistance to my hand. I am also observing the patient's face closely for indications of tenderness or discomfort.
Please take slowly deep breaths for me, slow deep breaths, and make sure to stay relaxed, okay? Slow deep breaths. Make sure to be relaxed.
If the abdominal muscles are tense, I will try to relax the patient and palpate gently again. Having the patient flex the knees is often helpful. I am then palpating by pressing more deeply in all four quadrants as I feel for any masses or tenderness. I am placing one hand on top of the other and watching closely for signs of an acute abdomen for inflammation of parietal peritoneum or peritonitis. Signs include abdominal pain with coughing, rigid or board like abdomen, guarding rebound tenderness, and percussion tenderness. I am percussing the span of the liver. First, locating the mid-clavicular line, I am using a light to moderate percussion strike starting at a level below the umbilicus in the light rovent quadrant in an area of tympani. I am percussing up towards the liver. I am identifying the lower border of dullness in the mid-clavicular line. Next, I am identifying the upper border of dullness starting at the nipple line. I am lightly percussing for lung resonance down towards liver dullness and measuring the span of liver dullness between these 2 points. I am palpating the liver by placing my left hand behind the lower thorax. I am lifting up the 11th and 12th ribs overlying soft tissues and placing my right hand just below the right upper quadrant, lateral to the rectus abdominis muscle and dwelling below the lower border of liver dullness. I am percussing gently into the abdomen as the patient breathes in deeply. I am trying to feel for the liver edge as it moves down to my fingertips. If it's possible, I will let the liver slip under my finger pads as I feel the anterior surface. The hooking technique may also be helpful. I am standing to the right of the patient's chest and placing the fingers of both hands below the border of liver dullness and pressing in and up towards the costal margin and asking the patient to take another deep breath. I am assuring for tenderness. When the liver is not palpable, I will place my left hand flat on the right lower rib cage and gently strike it with the ulnar surface of the right fist and I'll ask the patient to compare the sensation. I am palpating the spleen to assess its size. I will reach over and around the patient with my left hand to support the left lower posterior rib cage and overlying structures. I am placing my right hand below the left costal margin and pressing in with my finger towards the spleen. When the patient takes a deep breath, I will try to feel the spleen as it comes down to meet my fingertips. The tip of the spleen is palpable in only 5% of normal adults. Alternatively, I will ask the patient to turn on to the right side with the legs somewhat flexed at the hips. In the position, gravity may bring the spleen forward and to the right into a palpable location. To help detect splenomegaly, that is an enlarged spleen, I will percuss the left lower anterior chest wall roughly from the border of cardiac dullness at the sixth rib to the anterior axillary line and down to the costal margin. This is an area called trout space. As I percuss along this route, I will note the lateral extent of tympani. If tympani are prominent, especially laterally, splenomegaly is not likely. Then I will ask the patient to take a deep breath and percuss again with the spleen size is normal. The percussion note usually remains tympanic when the spleen is enlarged. Tympani often changes to dullness. Dullness is a positive sign. I am palpating the right kidney by moving to the patient's right side and place my left hand behind the patient just below and parallel to the right 12th rib with my fingertips and just reaching the costovertebral angle. I am trying to lift and displace the kidney anteriorly by placing my right hand gently in the right upper quadrant lateral and parallel to the rectus muscle. I am asking the patient to take a deep breath at the peak of inspiration and pressing my right hand firmly and deeply into the right upper quadrant just below the costal margin and try to capture the kidney between my hands. Asking the patient to breathe out and then stop breathing slowly, releasing the pressure of my right hand, feeling at the same time for the kidneys to slide back into its expiratory position. If the kidney is palpable, I will assess its size, concha, and any tenderness. I will do the same for the right kidney. I am examining the aorta by asking the patient to take a deep breath in slowly and let it out. I am assessing the aorta by pressing the upper abdomen slightly left of the midline and feel for aortic pulsations. Now I am trying to assess the width of the aorta, especially in old smokers at risk of abdominal aortic aneurysm by pressing gently with the hand on each side of the aorta and trying to estimate its width. Normally, it should be less than 3 centimeters. Next, with the patient sitting up, I will assess for costovertebral angle tenderness seen in pyelonephritis. I will place the ball of my hand and on each costovertebral angle in turn and strike it with the ulnar surface of my fist. Normally, there is no tenderness over normal kidneys. There are two other additional techniques for testing the shifting dullness by percussing the border of tympani and dullness with the patient. If the patient is supine, then turning the patient onto one side and percussing again and testing for a fluid wave by tapping one flank sharply with my fingertips while I feel on the opposite flank for an impulse transmitted through the fat. Individuals with more body fat, we will need two sets of hands for this test. I will assess for possible appendicitis by searching carefully for an area of local tenderness called McBurney's point, which lies 2 centimeters from the anterior superior spinous process of ilium on line drawn from the umbilicus.